That's a lovely introduction, thank you. Right, it's fascinating for me as a Brighton boy, born and bred, to be talking in the Grand Hotel here and seeing all the scaffolding outside, because the last time it was this heavily scaffolded was back when the IRA bombed it in 1986. And of course, that's 30 years ago, and I remember that night very well. I remember all the sirens and everything. It's a big old night. They were all treated, all the casualties were treated up at the Royal Sussex County Hospital, which is about a mile away from here. And this is what the Royal Sussex County Hospital looks like at the moment. It's a building site. This is the view from theatres. It's rather nice, isn't it? So, old anaesthetic department over on the left-hand side there, a big old asbestos-clad building. And there's £500 million worth of new stuff going in there over the next, well, 5 to 10 years probably. The fact that everything that the county is a building site at the moment has meant there's been lots of changes, lots of sort of reconfiguration changes, and one of the results of that is that the hip fractures are all now treated 15 miles up the road at the Princess. Well, that's what it's going to look like. We're all treated 15 miles up the road at the Princess Royal Hospital now, and we've actually got a hip fracture unit pretty much up there now. We've got orthogeriatricians up there, we've got a small group of trauma surgeons, we've got a smaller group of anaesthetists delivering care up there, and they're all the patients are treated in one theatre and treated on one ward. And it's allowed us to standardise our practice a lot more. And this is the result of what's happened over the last 5 or 10 years with our hip fracture service at Brighton. And oh dear, God, what have I done there? Oh, there we go. We've got a laser on this. Unfortunately, you can't. Well, let's see. Have we got a laser? No. There is a laser, is there? Okay. 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 Okay, good. And so what we have done is we've reduced our mortality massively. Well, quite massively. We've halved it. And so now it's about half the national average. The length of stay and the post-operative bed days have also come down. The interesting thing is, that's when we set up the hip unit there. You probably can't see it at the back, but this is when we set up the hip unit there. Since we've opened the hip unit, we've been dealing with about 15 to 20% more patients, because we collect hip fracture patients from around Sussex and encroach on other people's areas now. And the ambulance crews like to drop off at Princess Royal Hospital because they get a very quick service. So despite a 20% increase in numbers, we've managed to keep ourselves, we've managed to carry on doing well. There's been a number of changes, of course, that have happened over this time. So, you know, back there we had a review by Keith Willett, the trauma czar, who came and told us what to do. We appointed some new orthogeriatricians, and they've been very good. The surgeons standardised their treatment about there. And towards the end here, we started standardising our anaesthetic treatment. And that's basically what this talk is about now, is you know, how can you go about standardising your anaesthetic treatment and delivering the optimal anaesthesia. We are, at Brighton, down here, we're definitely a spinal anaesthetic department. And I'm hoping I'm preaching to the converted. Hope that I am preaching to the converted here, saying that spinal anaesthesia is better for patients. Definitely better for hip fracture patients. That's not to say that you can't have good outcomes when you give general anaesthesia as well. So we're spinalists, we do a lot of spinal anaesthetics. There are some places that do lots of general anaesthetics. This is basically a graph from the NHFD and the ASAP data that shows people who do a lot of general, a lot of spinal, and those that are in the middle. Now, I think this is better. If you do lots of spinal anaesthetics, your patients do best. I don't have too much issue up here either. If you give a lot of general anaesthetics, then your patients do actually surprisingly well, because you've standardised your general anaesthesia as well. And so the nurses after hip fracture surgery, they know what to expect, they know what to look for, they know how to look after the patients after surgery. It's these ones in the middle that I have the main issue with. So if there's lots of variation around the country, it's those that just do some spinal, some general, different anaesthetists do different things. They're the ones that tend to have the worst outcomes. Why do I say that spinal anaesthesia is better? Well, This is a sort of summary of all the data, data around the hip fracture anesthesia and outcomes. If you look at mortality, 30-day mortality, you don't really see much difference, even in big studies, even in 60,000, 70,000 patients. You don't see much difference. And it's not really surprising because you're looking at mortality 30 days after the 2-hour period of anesthesia. And it's unsurprising that we don't really have that much effect on 30-day mortality. Where we do see a difference is, it's not a huge difference, admittedly, but where you do see a difference is that spinal anesthesia appears to deliver better outcomes in terms of morbidity. And certainly in the early post-operative morbidity, that first 5-day morbidity, yeah, you do tend to see slight benefits of spinal anesthesia. And it's cheaper. And the reason we've chosen spinal anesthesia down at Brighton as the way forward, and why I promote it so heavily, is because this is what I want my patient looking like after having had their hip fracture surgery. So this is Margie. She's 94 years old. 10 minutes ago, she came out of having a PFN put in. And this is what I want. This is what I want all of my patients to look like afterwards. I want them to be sitting up in bed, no oxygen on because they don't need it, no fluids connected to the very small venflon because they don't need it, drinking a cup of tea. I just missed her smiling, actually, just as I took this photo here. But she just gave us a big, broad grin afterwards. And she's relieved, she's happy, she's ready to rehab now. She can go back to the ward later on this afternoon. She can be sat out by the physiotherapists or the nurses, and then tomorrow she can be back on her feet, learning to walk again. And that's really what we're aiming for with our hip fractures every time. If we can make a difference at all, then we've only got a very small time to do it. We've got a 2-hour period in which we can have an influence as anaesthetist. And I think we need to possibly rethink what the purpose of anesthesia is. What are we trying to do in that 2-hour period to get these hip fracture patients back on their feet? And if you reconceptualize what we're trying to aim for, if you think of what happens to a hip fracture patient's function when they fracture their hip there, they've often been declining for quite a bit. Then they fracture their hip and their function declines to nothing. Basically, they need to be completely cared for. We do nothing for them in hospital. We give them a pretty shoddy anesthetic, possibly a general anesthetic. They have hypotension, they have nausea afterwards. Then they go back to the ward, they become a bit hypotensive, we'll give them some fluids, make them a bit better over the next couple of days. Then they got a hospital-acquired pneumonia or something, and from which they recover over the next couple of days, and then they're sort of up and down, up and down, up and down, and they never really quite get back to what they were like before they fractured their hip, and they get discharged from hospital, and their function carries on declining. And that's typically what happens when you go and see other hip fracture patients in other units around the country. When you see those units that aren't doing so well, that's what happens to the hip fracture patients. What we really want to be aiming for, what we would need to have in our mind, as well as when we're looking at thinking of a picture of Margie, we need to have this idea in our minds as well, that we need to, this is the impact of good anesthesia. So we get involved as soon as the hip is fractured. We're not quite at the stage yet of going out into the ambulances, but it's not that far off. Why can't we promote better analgesia in the ambulances? Why can't we teach the ambulance people to actually put in blocks themselves? Patient comes into hospital, but they've had good analgesia, they've possibly had some fluids started in the ambulance, they haven't really declined to base level 0. They're better than they would be otherwise. Then we do good things in A&E, and we get them somewhat better, and then we give them a bloody good anaesthetic. And a bloody good anaesthetic is the rest of the talk, and I'll explain what's going on there. But if you give them a good anaesthetic, they don't have the problems post-operatively. They don't have many complications. They get better, they get better. Their trajectory heads back towards normalization for them. They get out of hospital quicker, and they don't decline after they get out of hospital. And that's what we're really aiming for, isn't it, with our anaesthetic, with our 2-hour anaesthetic intervention. That's what we're aiming for. We want to re-enable them. We want to get them back to as normal a function as possible. We're never going to make them 21-year-olds again, but we want to normalise their function as much as we can. So how can we achieve this for all our patients? And that's basically what we're talking about. What's the optimal anaesthetic technique? Well, I would say that it's this. It's minimally invasive, standardized anaesthesia. Now, what we've done over the last couple of years at Brighton is we've looked at all the evidence and we've come up with 10 standards. And they're written down, and they're in a laminated folder, and they're in Theatre 1 up at the Princess Royal Hospital for all hip fracture, all anaesthetising hip fracture patients to look at and try and follow. Because some people, you don't anaesthetize hip fracture patients that often. All of the rest of the talk is available on this website here, hipfractureanaesthesia.com, which contains all of the information and all the references that I'm about to tell you. And so basically, our 10 standards are these. We prefer spinal anaesthesia to general anaesthesia. If you do a spinal anaesthetic or a general anaesthetic, then you should always give a nerve block around the time of surgery. And if you give a spinal or a general anaesthesia, you should always use the least you can get away with. That's a low-dose spinal anaesthetic with no opioid and minimal sedation. And if you're going to give a general anaesthetic, then monitor the depth of anaesthesia, not because you're worried about whether they're going to be aware under general anaesthetic, but because you're trying to adjust the dose of general anaesthetic that you're given. And then there's some other ones at the bottom here. So the website that I talked to you about there, so we've got the aims of standardization, we've got the standards themselves, we've got their rationale, why have we advocated these standards, and what are the references backing those up, and the evidence supporting the rationale, and then importantly where the knowledge gaps are. And if any of you are interested in doing research or have or in active research academic units, it will give you some research ideas as to what to do. So spinal preferred to general anaesthetic, we do that because we want Margie looking like Margie after her operation, and the best way of achieving that, we think, is with spinal anaesthesia. Plus nerve block. We should always be giving nerve blocks to these patients. So what do we need to block? Well, we need to block the femoral nerve, we need to block the obturator nerve, the lateral cutaneous nerve of the thigh, because that's where the incision is on the hole, and the sciatic nerve to a lesser degree. There is a small posterior inferior aspect of the hip joint that's innervated by the sciatic nerve. Now, I've got absolutely no evidence for saying these two things here. My suspicion is that preoperatively, femoral nerve block is slightly better. So when they come to A&E, it's a slightly more technically complex thing to do, but a femoral nerve block is probably slightly better because it blocks the femoral nerve densely. And often what the patients complain of when they've got their broken hip before it's fixed is they complain of a lot of quadriceps spasm. And the femoral nerve block is probably a better way of getting rid of the spasm than a fascia iliaca block. Post-operatively, the fascia iliaca block's slightly better, I think, because it more reliably, I suspect, blocks the lateral cutaneous nerve of the thigh. And that's where the incision is made. I've added psoas compartment block there. I like doing psoas compartment blocks. If you give a patient, on the odd occasion that you have to give them a general anaesthetic, then once you've given the general anaesthetic, you can turn them over with the bad side up, and that puts them in exactly the right position to put a psoas compartment block in. It's got a lovely end point, and it's fun sticking a 10-centimetre needle into someone. But you have to be a little bit aware of the surgical approaches. There's been a paper out on anaesthesia recently that didn't really find much difference between fascia iliaca block and I think it was local anaesthetic infiltration into the hip. What they didn't look at was where the incision takes place. So about half the surgeons in the country do a lateral incision, i.e. right over the trochanter itself, whereas about half the surgeons do a posterior approach. And what I suspect is that the lateral cutaneous nerve isn't quite sufficient for those incisions where you've got a posterior incision. So it might not actually be blocking those. Of course, the advantage for having nerve blocks, I mean, I don't need to tell you this as RAUK, is that it reduces the amount of opioids in general that you need in the general anaesthetic, and it reduces the amount of opioids and sedation that you need in the spinal anaesthetic. Using low-dose, minimally invasive anaesthesia, whether it's general or spinal anaesthesia, is all about maintaining blood pressure, pretty much. And by maintaining blood pressure, therefore, you're avoiding ischemia. So by using low-dose anesthesia, what you're doing is you're reducing the exposure to delirium-inducing drugs. And generally, obviously, with general anesthesia, that's a problem. Sedation contributes to delirium, and delirium is a big problem after hip fracture anesthetics. It occurs in anything up to 40% of patients, and it stops them remobilizing. It stops them getting out of bed on day one. So that's important. Reduces the prevalence of hypotension, which we'll talk about in a second. It's something that we can do something about simply with the simple expedient of just giving less anesthetic in the first place. If we give less anesthetic, then the problems occur less often. They occur more slowly when they do, so you don't get that sort of falling off the edge of a cliff type of anesthetic. And you don't have to intervene quite so quickly or quite so drastically, and so you don't get the pressure waves up and down that you see in this type of anesthetic here. So this is a 2.5 mil spinal anesthetic for a total hip replacement. And as you can see, sawtoothing all the way through, where basically the anaesthetist is chasing their own anesthetic. And they're chasing it because they've just given too much spinal in the first place. And this is the problem with hypotension. If you give too much anesthesia, you cause hypotension. So what do? You reach for the fluid. So you give too much fluid, which the patients have to get rid of eventually, and they don't have the physiological capacity to deal with in the first place. You dilute out what remaining blood cells they do have after the surgeons have been at them, so they become anemic. And the effect of all of this is, if you're enlightened and you give them vasopressors instead, all of these things contribute to ischemia of the patient. And the ischemia manifests itself as brain ischemia, delirium. It manifests itself as heart ischemia, so they do have changes, lots of changes in their cardiac enzymes, whether it's clinically relevant or not. And they also get a lot of acute kidney injury as well. Their kidneys are usually just on a sort of a knife edge by the time you get to sort of 85, 90, and we come along and we kick them over the edge. So what do we do instead? Well, we give less anesthetic. You maintain normal tension. You don't have to give them as much fluid, so they don't become anemic. You don't have to give them as many pressors, so they don't become quite as ischemic. And we know that hypotension is a real problem. So I alluded earlier on to the ASEP project, and that was a prospective thing that happened a couple of years ago, about 11,000 patients, and some of you will have contributed to it. It's about 11,000 hip fracture patients over 3 months in the UK. And we found biblically historical levels of hypotension. So if you take the normal definition of hypotension here, the systolic, well, it's one of the many definitions of hypotension, but if you take the lowest systolic blood pressure of 100 millimeters of mercury here, 77% of all of the patients looking at their pre-induction or pre-spinal blood pressure and then comparing it to their lowest blood pressure. The lowest blood pressure here, 77% of patients had hypotension by this definition. The least bad definition, so that's a fall in systolic blood, it's a relative fall in systolic blood pressure of 20%. 90% of patients had that. And really, rather worryingly, was that 32% of patients had a mean arterial pressure of less than 55 millimeters of mercury. Now, that's the threshold that we know from some studies from the States where problems really start to occur, where death rates start to rise. What was interesting about this here was that in all cases, and contrary to what you might expect, with spinal anesthesia, the prevalence of all definitions of hypotension was less common with spinal anesthesia than it was with general anesthesia. So it seems that we're slightly better at giving spinal anesthetics than we are at general anesthetics for the elderly. We went on to reanalyze this data in a separate paper a bit later on, where we looked at the mean arterial pressure, and as it declines here, if you take these thresholds and you look at the death rates at 30 days in people who have a lowest mean arterial pressure above 75, and those who have a lowest mean arterial pressure below 75, and then if you take it for the different thresholds, you actually find as you get down towards this 55 millimeter figure again, that 30% of patients have, you find that actually the death rate starts to go up, and it significantly starts to go up if they've become hypotensive. It's only an association, but it's an interesting one. So what can we do about it? Well, I've mentioned minimally invasive spinal anesthesia. Well, this is some work that we've done at Brighton. So as you reduce the amount of local anesthetic that you inject into the subarachnoid space, you find that the relative fall in blood pressure decreases. So this was data from Brighton, 1,100 patients. Some people still given 4.5 mils spinal anesthetic. My God. Well, one person anyway. But more commonly, 2 to 2.5 mils, because of course people learn on obstetric patients how to give spinal anesthetics, and that's what you do in spinal anesthetics for obstetric patients. And they don't dial it down for the elderly patients who just need unilateral blocks. But as you get down, it's not only is the fall in blood pressure less, the less you give, it's actually more predictable as well. The fall in blood pressure is more predictable. So you get wide ranges here. You get some whose blood pressure doesn't change much, but some whose blood pressure changes a lot. Whereas down here, you know that the blood pressure will vary, but it won't be by much. That's all very interesting, but it's single center observational stuff. But we managed to repeat it with the ASAP data. So this is multi-center now, multi-center observational stuff. And we found almost exactly the same thing. Again, there's still someone out there giving 4.5 mils. I don't know whether they're from Brighton or not, but it's the same type of thing. Again, lots and lots and lots and lots of spinals are in the 2 to 3 mils range. There's only about 15% were less than 2 mils. But again, you see the same type of thing. It's down here. It's down at 1.5 mils that you get that minimal hypotension. So it sort of confirms what we found in Brighton. Now, of course, that's all very well. That's observational stuff. What about doing something a bit more direct? So this was some data that we got from that we did in Brighton, or probably about 5 years ago now, using 1 mil of 0.5% heavy into a spinal for DHSs. We did it on 14 patients who were sick-ish. They were sort of ASA 3, Nottingham hip score of 5 out of 10. But of course, these are patients who can consent to, but almost by definition, they're one of the fitter groups of hip fracture patients. But if you stick an arterial line into them and then give them a 1 mil spinal, then this is what happens to their blood pressure. And if you measure the blood pressure every minute or so. Mean arterial pressure in green, systolic blood pressure in here. And this is the point where you put the spinal in. You notice that there's quite a lot of hypotension that happens. If you look at the relative fall in blood pressure, there's quite a lot of blood pressure fall even before you put the spinal in. That's probably related to the propofol that you're given to turn them in the first place. But you see a drop-off to start off with, and then it sort of comes back to normal. It never really quite gets back to normal 35 minutes later, but if you carry this on, it does get back to roughly their baseline blood pressure after about 50 minutes or so. What you'll notice here, this red dotted line here, is that the blood pressure has only fallen by about 10% with 1 mil, and that's good. That's fantastic. That is cardio-stable anesthesia for hip fracture for the elderly. So, like I mentioned, this was about 5 or 6 years ago. I didn't publish this. I'd answered the question in my own head. I was quite happy with it. So I didn't really think any more about it. These are, like I said, these are not truly representative of all hip fracture patients because they're a bit more with it and a bit less sick. What we have done recently, though, is we found a way of just ripping data off the anesthesia monitors and recording it electronically on an iMac. And so this is all quite useful. This is something that you could do if you're interested in this type of thing in your own hospital. And I'm now using 1.3 mils rather than 1 mil because I think it gives you a little bit longer time to do the operation. And this is the last 21 patients that we've done. And these are all comers. So these are all patients. These are sick patients, the sickest patients, the oldest patients, even patients who wouldn't be able to consent to take part in the study normally. So this is just observational data with 1.3 mils. And you see a similar type of thing. This is non-invasive blood pressure now, recorded every 2 minutes. And you see a similar type of thing. Again, about less than a 20% fall in mean diastolic and systolic blood pressure. So there seems to be something there. This needs to be formalized in proper research, but the less you give, the more cardiostable your anaesthetic is. So that's all very well. It's all lovely to be able to say, well, yes, we deliver cardiostable anaesthesia, great. Does it affect their outcome? Well, like I said, the Haywards Heath hip fracture unit's been open for about getting on for 2 years now. We've got standardised orthogeriatric care, we've got protocolised care, everything's pretty much standardised. We've started standardising the anaesthetic procedures. The information is all there for my colleagues, several of whom I can see in the audience, only about half of whom actually follow the standards. For me, that's fantastic because it presents a research opportunity. So I can now compare the outcomes between patients who have had standardized anaesthetic and who haven't. So looking back over the last 577 patients that we've had, 79 have had general anaesthetics, a couple have had general and spinal anaesthesia. Those anaesthetists have been re-educated. And about 500 have had spinal anaesthetic. Now, we know the dosing about 490, and about half and half, they've either had the low-dose spinal anaesthetic, so that's the standardized spinal anaesthetic, or they've done what they wanted. And if you look at all the patients in our hip fracture unit, which I do, and look at their outcomes in the first 5 days. So this is what the orthogeriatricians who are very good at recording data, this is what they write in their notes. And I go through the notes and I look for complications that they treat. We haven't actually found any significant differences in outcome in less than 5 days between general anaesthesia and spinal anaesthesia. The anaesthetists at Brighton are very good at following general anaesthesia guidelines, very good at following the standard general anaesthesia guidelines, less good at the spinal ones. But if you look at the standardized, so the low-dose spinals versus whatever you want to do spinals, you see that actually there are significant differences in these outcomes here. In the low-dose spinal group, 35% of them have no complications in the first 5 days, whereas only 24% do in the higher dose group. There's less delirium, it's not quite significant. There's less pain. Why should that be? It's because, I haven't got the data here, but the high dose group, they rely on diamorphine, given with the spinal to provide post-operative pain relief, whereas the low dose group put blocks in. And I think that's probably where the difference is. There's less hypotension and there's less constipation. Now, you may laugh at constipation. It's not a laughing matter for the elderly, though. It's the thing. It's it's very prevalent and it keeps them in bed afterwards. So if we can do anything about it, then that's got to be a good thing. Importantly, if you then start comparing the general anaesthetic to the low-dose spinal anaesthetic, so this is pretty much standardized general anaesthesia versus low-dose spinal anaesthesia, you see differences again. So same figures as before for the low-dose ones, but if you compare them to the general anaesthetics, then yes, a lot more of them have no complications at all. Delirium rates are lower, not significantly. Pain is lower, and I can't really quite explain that one. Hypotension occurs less commonly, and again, less constipation. So there seems to be something there. Now, we'll publish when we've got larger numbers, but it does tend to indicate that if you give lower dose spinal anaesthesia with a block, you have improved outcomes, and that would be one of the first papers to show a difference really between them in anaesthetic technique. So I'm sorry about this one. This one is on the hip fracture anaesthesia website. You want to know what the optimal technique for hip fracture anaesthesia is? Well, it's basically this. Put the monitoring on, give them some fluids and stuff, put an awake fascia iliaca block in, a little bit of oxygen, monitor the blood pressure rigidly, give them a little bit of propofol possibly to turn them, or wait a little bit longer for the fascia iliaca block to work, and then put in a low-dose spinal anaesthetic, so low-dose meaning no more than 1.5 mils for anything other than a total hip replacement, which is 1.8 mils. Keep an eye on their blood pressure, yeah, and that's good. Sit them up again at the end of theatre, give them a cup of tea. And I'll leave you with that. That's what you should be aspiring to every time with your hip fracture anaesthetics. Thank you.
Does anyone get any questions for Stuart? I see a couple of hands up already. 3.
Yeah.
you seem to group all hip fractures together, and I, for one, slightly take issue with that in that I think, both surgically, hemiarthroplasty and a DHS are very different operations.
Yeah.
They're often very different, both obviously in surgical approach, but often in the timing that they take. And a 70-year-old lady that falls over, who's otherwise healthy and gets a hemi, is more akin to a total hip replacement patient that we would use perhaps a different technique on. So, whilst I'd love to standardise, I don't think you haven't explained that in your data, and if you could, and perhaps break it down a bit, I'd be a bit more on board.
Yeah, I think that's a fair enough point, actually. I mean, this is that was very sort of summative data. Certainly, yeah, we certainly could look at it, but once we've got larger numbers, we could certainly look at it by DHS, hemiarthroplasty, and the like. It's a fair point.
Okay, two more quick questions. We need to.
For these patients, to prevent the fall of blood pressure, is there any role of using metronidazole infusion almost from the beginning?
Yeah, it's an interesting one. You see, I would say metronidazole infusion. There is some data to show that you should be using a phenylephrine infusion instead. I still suspect that a metronidazole infusion is there to counteract the propofol infusion you're giving through the other Venflon. So I don't think, to be honest, using the low-dose spinal anesthesia, I don't think you need to use a metronidazole infusion at all. You just don't see the falls in blood pressure. You don't get any, my suspicion is you don't get any extra cardiovascular stability by using a metronidazole infusion.
Thanks.
Just give less anesthetic.
One last quick question by Ollie.
Stuart, Alan, thank you very much. I guess you know what I'm going to ask about, but so considering the period of hypertension, which I think can be really important as well, not just the intraoperative hypertension, when you use bupivacaine, even low-dose bupivacaine, which, by the way, less than 10 milligrams is actually an off-label use of Marcaine, and that's probably why you have a higher potential failure rate. But that post-operative hypertension must be a consideration as well. And that's why in my practice, and I agree, I do femoral nerve block with an adductor, an anterior obturator, I use prilocaine. Now, sure, as we heard comments about spinal, about the duration, that's really important. But, I have a spinal anesthetic that basically lasts effectively as long as the surgery. So I don't have issues of hypertension and recovery. Pain management as well is right there. I mean, do you think that maybe this is something we should consider as well?
Yeah, it's interesting. I mean, I've just presented some of the data there about heavy Marcaine. You get exactly the same types of hypotension graphs with plain Marcaine. In the ASAP data, there were some people who used prilocaine, but not a large enough number. Not a large enough number for us to really analyse with any confidence as to whether it was a good thing or not. Yeah, go out and do the research. I mean, I always end up whenever I'm giving a speech here saying, go and do the work. I mean, that's basically all of you. These are common enough patients that and there are large enough gaps in our knowledge that you just need to go out and do the work. And I agree. I'd be really interested to see a good paper on how long prilocaine lasts, what the cardiovascular stability of it's like. Great, do it.
We need to.
You do get the same with plain Marcaine, yeah. So if you give 1.5, you get almost exactly the same graph. If you give 1.5 mils of heavy Marcaine or whether you give 1.5 mils of plain Marcaine.
Okay. Right, we need to move on. I'm so sorry about that, but thanks very much to Stuart for that talk.